dissecting these papers today. So let's start, Gaurav.
Yes, sir. So I hope my screen is visible and I am audible.
Yes, it's visible now.
Okay. So good morning, everyone. My paper is titled as Age Influence upon Glenohumeral Remodeling after Shoulder Axial Rebalancing Surgery in Brachial Plexus Birth Palsy. This paper is published in Journal of Pediatric Orthopaedics, May and June edition 2023. And this paper is from France, from the Department of Pediatric Orthopedics and Reconstruction, Armand Rozier Hospital, and Hand to Shoulder Mediterranean Center, France. The authors include Melo Lihano, Lilia Brahim, Tristan Langlaise, Pere Alban Bosch, and Frank Fitosi. So it's a retrospective case series. We all know that shoulder rebalancing procedures have been proven to provide satisfactory functional improvements in shoulder external rotation deficits. However, the influence of age at the time of surgery on post-operative osteoarticular remodeling remains unclear, especially regarding the age limit after which significant changes can no longer be expected. And this is the aim of this study. So it is to assess the impact of patient's age at the time of surgery on post-operative glenohumeral remodeling and to identify a cutoff age after which such remodeling would no longer be significant. So this study is basically based on comparison of preoperative and post-operative MRI measurements. So between January 2012 to January 2020, they did 69 patients. There were 69 patients who underwent surgical management of active shoulder external rotation deficit. Out of these, 20 were excluded. 7 were excluded because they had an additional shoulder procedure like tendon transfer to reanimate shoulder abduction, a glenoid anteversion, or a humeral derotation osteotomy, as they can affect the outcomes. 9 were excluded because the follow-up was less than 12 months and 4 lost to follow-up. So out of 69, 49 were included who underwent surgical management of active shoulder external rotation deficit without additional shoulder procedures and with at least 12 months of radiological follow-up. Out of these 49, 41 had tendon transfer and concomitant anterior release, and 8 had isolated tendon transfer. Out of these 49, 28 were girls. All of them were of term delivery with a slight overweight. 48 out of 49 had vaginal delivery and 1 had a cesarean. 30 out of 49 had right-sided affection. Out of these 49, 15 were of Narakas grade 1, 5 had Narakas 2 injury, 17 Narakas 3 and 12 Narakas 4. And out of these 49, 27 had nerve surgeries in form of nerve grafts and nerve transfers, and 7 had other surgeries like wrist extension tendon transfer, elbow flexion tendon transfer, and forearm derotation osteotomy. So out of these 49 tendon transfers, 43 had latissimus dorsi as the donor, and 6 had lower end of trapezius as the donor. And 41 out of 49 had shoulder anterior release, out of which 24 had open release, and 17 had arthroscopic anterior release. Reconstructive surgeries like nerve reconstruction and transfers were done between 6 to 18 months of life, depending upon the spontaneous recovery. And tendon transfers for shoulder external rotation were done after 18 months of age. In patients, can we mute the meet?
Yes, just a minute.
So tendon
ऑफिस कितने बजे देंगे? 9:30.
Can we mute the participants, please?
I don't know where this voice is coming from. So all these are mute. So Maharshi, I think this, let me mute Maharshi.
Yeah.
Muted.
Yeah. So tendon transfers for shoulder external rotation deficit were done after 18 months of age in patients with less than 0 degree of active shoulder external rotation with arm adducted. And latissimus dorsi to infraspinatus was the first choice. And in those patients where latissimus dorsi was weak, lower end of trapezius was used. Anterior shoulder release, either open or arthroscopic, was performed in patients with less than 30 degrees of passive external rotation, with the aim to achieve at least 45 degrees of passive external rotation intraoperatively. MRI was done preoperatively at 12 months post-surgery, and then it was repeated every year. Data was reviewed by an independent surgeon. Data collected included patient demographics, history, surgical information, pre- and post-operative MRI data. And MRI data basically included glenoid version, glenoid shape, percentage humeral head anterior to the glenoid midline, and glenohumeral deformity. So they found that there was a significant improvement in the mean glenoid version, glenoid shape, PHHA, and glenohumeral deformity in the entire cohort. Then they did comparison of the difference in improvement on MRI in groups less than 5 years and more than 5 years. And they found that the difference in improvement was significant in kids less than 5 years of age as compared to kids more than 5 years, where the differences were not significant. As I told, they also did an age-based subgroup analysis of MRI improvements, and they found that the improvements were significant in kids less than 5 years of age, whereas it was not significant in kids more than 5 years of age. They also found out that the improvement in these MRI parameters significantly decreased per additional month of age at the time of surgery. So as the time of surgery increased, the MRI parameter, the improvement in MRI parameters decreased as 0.19 degrees per month in glenoid version, 0.02 grade per month in glenoid shape, 12% PHHA per month in percentage humeral head, and 0.01 grade in glenohumeral deformity per month increase in the age. And they did a statistical analysis where, on the basis of regression curves, they found out that the threshold of 5 years was identified to be the age at the time of surgery, after which differences between pre-op and post-op MRI values would decrease and will not remain significant. They compared their study with the previously done studies. So Waters group did a study in 2005 over 25 patients where the mean age of surgery was 3.5 years. And in that study, latissimus dorsi and teres major transfer were done along with musculotendinous lengthening. They found that the MRI parameters like glenoid version, PHHA, and glenohumeral dysplasia improved, however, not a very significant improvement as compared to their 2008 study where the age at surgery was lesser. It was 2.3 years. And the improvements were significant or more as compared to the kids with age 3.5 years. Similarly, Cousin et al. Did two studies in 2010. And the age at surgery was, in one study, it was 2.7 years, and in the other, it was around 5 years. And they also found that the kids where the age was 5 years, the MRI parameters were not significantly improved. One more study which they compared was by Gemal et al., who did a CT-based study in 2006 over 109 patients, where the mean age of surgery was 4 years. And they also found that there was a significantly higher residual glenoid retroversion in patients who were operated at 4 years. Also, there was a significantly higher residual humeral head subluxation in patients operated on or after 2 years. Now, why this significant residual deformity at younger age? This might be due to the assessment method, as CT scan does not consider the cartilage margins as compared to MRI. In this study, there were 3 cases where there was aggravation of pre-existing glenohumeral dysplasia, and all these 3 patients were over 5 years. And so they also suggest that that is why kids over 5 years with glenohumeral dysplasia, we should think of other procedures like derotation or glenoid anteversion rather than considering tendon transfers. They also had 9 patients without any preoperative glenohumeral dysplasia where they did tendon transfers to achieve active shoulder external rotation, and they found that there was no significant remodeling post-operative imaging in these patients, suggesting the harmlessness of these surgeries. Limitations included a relatively small sample size.
So,
They
can
also
we hear Gaurav or I
Yes, sir.
cannot hear Gaurav?
Am I audible?
Yes, sir, you're audible, sir. Gaurav is audible, sir.
Sir, are you able to hear me, Maulin sir? I think Maulin sir is not able to hear me.
गौरव का सुनाई दे रहा है? कैसे?
We are able to hear you, Gaurav.
So, shall I continue, Meet, or shall I stop?
Yes, please ask, sir.
Meet, can you have a word with Maulin sir? Meet, are you there?
Yes, I am here.
So,
Sir,
sir,
are
का
you
वो
audible, sir? Just a second.
हाँ ठीक है, I'll wait.
Sorry, Gaurav. Again, I turned deaf. I don't know why.
So now am I audible to
Give me
you?
a minute, so I'll attend with Meet now, so I can listen.
Okay.
Or you can go ahead in your presentation. You go
No,
ahead
sir.
with your presentation.
Okay. So the limitations included a relatively small sample size, and they did a multivariate analysis to assess the effect of other factors like type of transfer, type of release, preoperative Waters grade. And they found that age was the only factor which had a significant impact on the results. However, due to small sample size, there can be statistical error, and one cannot consistently say that there is no impact of other factors. Also, the donors they used had different lines of actions, and different release procedures were performed. Follow-up was short of skeletal maturity, and we can expect some progressive gradual improvement in the dysplasia, and that has been missed. Also, they have not used any clinical outcome measure or functional range, because of which no conclusion can be drawn regarding the clinical outcomes of these procedures. So to conclude, in patients with glenohumeral dysplasia secondary to brachial plexus birth injury, axial rebalancing procedures seems to allow for significant remodeling of the joint, glenohumeral joint, provided the age at the time of surgery is less than 5 years. In my practice also, it reinforces my existing understanding about the glenohumeral remodeling, And I would be more vigilant in assessing kids with shoulder external rotation deficit above 5 years by getting an MRI and seeing if there is a significant glenohumeral dysplasia. I would err towards doing other surgeries like derotation osteotomy or glenoid anteversion osteotomy rather than going for tendon transfers. So thank you for your patient listening, and this paper is open for discussion now.
Gaurav, this is a basically a very specialized paper. My concerns regarding this paper were basically what were the different indications, because nerve surgery and tendon surgeries are indicated for different category of the patients. Okay, with nerve surgery, when nerve surgery is performed, the deficit is likely to be more severe than the tendon surgery. Okay, do you think this factor was accounted for in the study?
Sir, they have not elaborated about this, but they have said that these patients underwent nerve surgeries previously who had severe deficits, because they have included all Narakas grades, and those who had limited active shoulder external rotation less than 0 after 18 months of age. In those, they have chosen these shoulder rebalancing surgeries.
Second thing regarding the article was that they have made statistical calculations in a sample size less than 10.
Sir, sample size was 49.
49, but the groups they compared, one was 41, the other was 9. When you compare small groups, statistical power is basically very much less for the study. Although I can understand that entity is rare and differentiating between two groups is also rare, but when you do a calculation over 9 patients, the impact or the statistical significance is somewhat limited. They have also mentioned this in their limitation. Okay.
Yeah, Mandar.
Third is the
please go on.
Third is the difference in the ages in which the surgeries have been performed. Okay, it's not regarding the age. You see that the nerve surgery was performed at ages less than 6 months in some cases, whereas the tendon surgeries were always performed at a bigger age or say older child. Okay, so it is expected. Have they compared the initial dysplasia present in the 2 cases?
Sir, they have measured, first of all, the groups they have compared were less than 5 and more than 5, and
No, this is the age group. This is not the slide. Between the 2 groups, the initial dysplasia.
So they have took the mean of all the MRI parameters, and they have kept one group less than 5 and one group more than 5. So they have,
This is the combined group. This is the combined 49 patients.
Right, sir. And this is the one where they have used less than 5 years and more than 5 years, and they calculated the average.
But they have, you can see that they have not done an analysis for the subgroup in which the nerve surgery was done and the tendon surgery was done.
Yeah, they have just over a blanket, they have told that these many kids have got a nerve surgery. They have not separated them, that those who got a surgery and who didn't got a surgery, and how was the result in those.
And I would like to have sir's opinion, if sir is able to connect. What are the Maulin sir's comment on this? Because we don't do much of this surgery. Our personal experience regarding this is limited, and if Dr. Mandar wants to add something.
Maulin sir, are you listening us?
Sir, they'll be connecting in a minute, sir. Sir will be connecting in a minute. There's some problem with the connection.
Mandar sir, do you have a comment?
I basically agree with what Gaurav said, is that this basically confirms what we instinctively feel about brachial plexus palsy, which means that the earlier that you do a shoulder rebalancing, the better it will be the glenoid outcome. So I think this is a good paper, though what Agrawal sir said is also absolutely right, that they should tell us in whom the nerve surgery has been performed, because that signifies that it was a slightly more severe disease from the start.
Right, sir.
I think it's a good paper. We'll wait for Maulin's expert comments about this. But this
I will be that MRI would need an anesthesia for that child. Last thing I would like to say that they have not mentioned the clinical outcome. We have seen in many patients glenohumeral joint remodels completely, but still the child's posture of arm is internally rotated, and it is due to the the humeral version which changes. And we have researched this through a concomitant shoulder and elbow imaging. So in about 10% children, they have persistent internal rotation of arm with elbow pointing laterally. And there we need a secondary derotation osteotomy after a primary tendon transfer. So this is a good paper. This is not going to change our practice. We have been doing this, but for those novice, this is a good indication that after 5 years, you might add glenoid anteversion or you do a derotation osteotomy. Yes, Gaurav.
Sir, I have a few questions. One is...
Gaurav, I think we should move on to other papers. Otherwise,
Okay,
we can discuss it on our fellows group.
Right,
We already need 20 minutes. Yeah, let's discuss second paper now. Goda or Sheenam can share the screen.
Yes, sir.
We'll keep our presentation limited to 5 to 7 minutes so that we have enough time to discuss, right?
Is it visible?
No, Goda, your screen is this visible, but the presentation is not coming up.
So, is it visible?
Maulin?
Yes.
Yeah, this is Mandar. I'll just have to put off for the next 15-20 minutes. I'll rejoin if I finish it soon. Yeah?
Okay.
Thanks. I'll just, yeah, thanks.
Is it visible?
No, Sheenam, can you double click on your PPT where we cannot see this? Can anyone else see Sheenam's presentation on screen?
No, sir. No, sir.
हाँ, शीनम उसको डबल क्लिक करना है. ये तो वो हम तेरा वो बेसिक स्क्रीन देख रहे हैं, PPTs वाला.
Okay.
You want to reshare? Try and share again.
Is it visible
Yes,
now?
yes. Yeah, please go ahead.
Okay. Good morning, everyone. I'm going to review this publication titled as a prospective multicenter study of developmental dysplasia of the hip and the expectations of patient after open reduction. It was published in Journal of Pediatric Orthopaedics 2023 by involving 16 institutions from 6 countries. The purpose of this study was to assess early outcomes of open reduction for DDH with specific intention on redislocation proximal femoral growth disturbance and residual acetabular dysplasia. It was level 2 study, prospective comparative study. 432 patients were assessed for eligibility and 194 patients had follow-up of less than 1 year. So only 195 patients were included. Proximal femoral growth disturbance was reviewed using Salter's criteria, but answering with yes or no. Residual acetabular dysplasia was defined as acetabular index more than 90th percentile for age. Median age at open reduction was 19 months and at follow-up was 21 months. It was seen that redislocation was seen in those patients in whom post-operative immobilization period was less, and residual dysplasia was seen in patients who were operated at increased age, and there was eccentric ossific nucleus present, and there was no previous treatment with harness or anything. Proximal femoral growth disturbance was seen in patients with increased age and unilateral DDH, and in there was no clinical reducibility before open reduction, and there was no previous treatment with harness, and the patient who were treated with adductor tenotomy, acetabular osteotomy, and femoral shortening osteotomy. It was found that redislocation was seen in 7% patients, and pelvic and residual dysplasia was seen in 39% patients who underwent pelvic osteotomy at 1 year follow-up. And 78% residual dysplasia was seen in 78% patients who didn't underwent pelvic osteotomy, and after 2 years it was seen. Proximal femoral growth disturbance was seen in 43.9% patients. They concluded with this, early treatment can decrease the rate of adverse outcomes. Proximal femoral growth disturbance and acetabular dysplasia can be reduced by performing pelvic osteotomies at the index procedure itself. Postoperative immobilization period can reduce redislocation. Limitations of this study was small follow-up, and author did not describe type of pelvic osteotomy, and there was no pre-operative IHD classification was described in the hips who were redislocated. Author did not distinguish clinically significant proximal femoral growth disturbance from other subtypes of growth disturbances. Utility in my practice, obviously, with this evidence of study, I would prefer to do pelvic osteotomy at the time of index procedure itself, and I will try to increase post-operative immobilization period. Thank you.
Sheenam, very well read paper. Thank you. Can you, how much post-operative immobilization they kept? What was an average period of immobilization?
So it was, yes.
Yeah, hip spica.
Yes, sir. So it was 100 days in the hips who were redislocated.
So you mean they immobilized children for 3 months, which were not dislocated, and less than 3 months. So what was the cutoff?
Sir, it was not described.
Not described, sir.
Oh,
Not
it's not this.
Yes.
Okay. The second
Yeah. Yes.
question is, like, now there are studies which shows that after primary open reduction, we should wait till the age of 5 years, and about 60 to 70% hips, they do not need secondary procedure. Means, so this follow-up of this paper is too low to indicate, because just 2 years follow-up, if I have operated a child at 1 year with open reduction, I have 2 years follow, so that child has still chance to remodel to a normal acetabular index. So that's a question, does that mount that we should do index pelvic osteotomy in all this index procedure? You understand what I mean?
Sir, can you please repeat?
So the follow-up is 2 years.
Yes.
And there are papers, one from Manipal itself, who is the Hitesh is co-author, that about 60% hips remodel at 5 years. So what I mean is they should follow these patients for longer time, and some of those patients who have not remodeled to their normal established would remodel. So this rate of less remodeling will improve. So this study needs longer follow-up, you know. So the conclusion which they have made that you should add pelvic osteotomy at index procedure is a too early conclusion. You cannot put that conclusion unless you follow those children till 5 years. But that till that time you see some improvement, and some of the authors have published that thing before. Dr. Anil, what is your suggestion?
I would like to add certain comments there. The power of this study is that it has utilized the pool data. It's a prospective study. And second, they have utilized the multivariate analysis. So in this sense, this paper has several strengths which other papers did not have. I agree with your comment that they have not mentioned, although they have used the 100 days as the cutoff for the post-operative immobilization, but they have not specified what reasons. They have just said that lower post-operative immobilization led to redislocation, but they have not given the precise period for which the hips should be immobilized. One thing also worried me, they have mentioned that the avian rate was high in cases. Avian rate was higher in cases where adductor tenotomy was performed. I agree that if you do concomitant pelvic osteotomy or femoral osteotomy, the procedure is a bit longer and more extensive, but adductor tenotomy is often used. It is done from the other side of the hip, and it helps in better alignment and should reduce the proximal deficiency, this proximal femoral growth disturbance, rather than increasing it. It relocates the hip. Second thing is that their rates are somewhat very, two rates are very much on the extremes. They said the redislocation is 7%, just 7%, which I think is a bit low in clinical practice. Second thing is that they mentioned the rate of proximal growth disturbance as high as 44%. I think both are near about 30%.
So that's a very valid point Sheenam raised, that see, growth disturbance can be there, but whether that growth disturbance is alarming enough to do some secondary interventions. Even that's in cases of AVN, where type 1 AVN does not need any treatment, while type 2, 3. So they should also subclassify the growth disturbance, which will happen when they follow this cohort for further period of time. But what is your practice, Dr. Anil? If you do an open reduction at the age of 18 months, would you add Salters or Dega?
I usually do, sir.
Okay, so I have not been doing, and there is very few now. We are working on that number, but very few patients they come back. They need to come back for Degas or Salter later. So I started this practice, and then I read a few papers. Although the stitching in sick kids, which is Salter's Institute, they say that after 18 months, acetabular does not remodel. And they used to put osteotomy in all the cases. But now we have huge number of pool, and I'm sure you would also have. And this paper suggests, and I'm sure I would be asking to Hitesh and Alaric, that they are part of this study, and what is happening in their older patients where they have done only open reduction in a retrospective manner if they have observed. So thank you, Sheenam, for this paper, and thanks, Anil, for your inputs. Let's move on to the third paper now.
Thank you.
So it shows that even the best the papers who have studied with good statisticians, they are lacking some information which reviewers have not came across. Goda, would you like to share your screen?
Yes, sir.
Sir, one thing this paper has, they described vestibular dysplasia as percentile, which in other papers they have defined as a specific cutoff. This is good about this
they have
paper.
looked at the age specific vestibular index.
Yes.
Anyway, let's move on to the next paper. This is a very interesting paper. Yeah, Goda, please go ahead.
So this was a study by Anil et al. It was on subsequent forearm fractures following initial surgical fixation. It was a retrospective study conducted. The patients were taken between 2011 to 2019. All the patients operated during that span were taken into consideration. So the rate of refracture generally for elastic stable interlocking nails ranges between 1.2 to 10.4%. For plating, it is 6.9 to 8.5. And generally, there is 40% risk of refracture following an elective plate removal. So in literature, there has not been any consensus on how to treat a refracture post-surgical management. So the objective of this paper was to investigate the refracture rate and the pattern of refracture that occurs after surgical intervention and how to manage these cases. The inclusion criteria was the diaphyseal fractures, metadiaphyseal fractures, and which were treated with either a plate or a nail, and the age at the time of resurgery should less than 18 years. These were the inclusion criteria. And the pathological fractures and underlying neuromuscular conditions were excluded. The patients were categorized into nail group, plate group, and hybrid group. The hybrid group eventually was added either into the nail group or a plate group based on the plate and the nail that was done. 349 patients were studied, and out of them 92 underwent plate fixation and 272 underwent nailing. 15 had hybrid surgery where one bone was nailed and one bone was plated. Of all the 349, 24 patients had a refracture, and in them 14 were nailed initially, and the plate group consisted of 10 patients. 10 of them were plated initially. So the age at these are the statistics. So the mechanism of re-injury was either with wheels or sporting activities, fall from standing heights or trampolines. And the age at the initial presentation in the nail plate group was 11 years, 11 plus or minus 2, and in the nailing group was 9 plus or minus 3. There was more male preponderance, and there was no statistical difference between time to subsequent fracture between the plate and the nail group. And following this secondary surgery also, 3 patients got their plate removed and 6 got their nails removed. The tourniquet time was significantly lower in the nailing group, and the subsequent fracture type, like both bones, were involved in 7 cases in the plate group and 8 in the nailing group. Radius was involved in 3 in the plate group and 4 in the nailing group, and ulna was not fractured in the plate group, but 2 patients were seen in this nailing group. And 90% of the fracture in the plate group occurred at the plate edge, and 75% occurred at the original fracture site in the nailing group. Most of the patients in the plating group had to be managed surgically, and most of the patients in the nailing group, they were managed conservatively. So this shows that this paper actually showed that there was a subsequent fracture tended towards a lower rate in the ESIN group, and even if there was a fracture, it could be managed conservatively. And coming to the discussion part, so the refracture rate of this paper was consistent with that of previous literature. That was about 10.9 in the plate and 5.1 in the nailing group. And the time to refracture was also similar to other literature things. But one specific difference this study showed is that in the nailing group, Mackey et al. Showed that less than 6, if the nail was removed, the refracture occurred less than 6 months of the nail being removed. And after 6 months, there was less chance of refracture. But the present study showed that there was no difference between that 6 months time group, which was mentioned by Mackey et al. And this Mackey et al. Also showed that there was a higher refracture rate following plate removal within the first 1 year. That was not seen in this study. And 90% of fractures occurred at the plate edge for a plating group and 79 at the original site. And this was already mentioned before slides, that the refractures in ESIN were managed mostly with close reduction. The operative time was shorter, and it showed that the treatment with ESIN initial treatment with the nails had better prognosis. And one interesting point in this paper was that the previous literature by Han et al. Showed that lesser than 20 degrees of angulation at the nail could be managed with close reduction and casting, but greater than 20 degrees, it was not possible to correct it, and hence they went for removal of the nail and reinsertion of a new nail or plating. But the present study showed that there was no macroscopic evidence of metal fracture or fatigue after 1 cycle of nail being reversed, even if it was greater than 21 degrees. So this study showed that even 20 degrees of angulations with ESIN in situ could be managed conservatively. So this is one figure that they have put up in the study, showing this was about 30 to 35 degrees of angulation, and the nails were also bent, but they still could manage it conservatively. This was not mentioned in previous literatures. And the other things were consistent with the previous literature, like refracture rate of 7.3% after plating. Clement and colleagues showed this, and 83% required second surgery. It was almost similar with the present study as well. So what were the complications that were seen in this is no in post-operative or intraoperative complications in the plate group, but during the follow-up, like subsequent follow-up, 3 of the patients got the implants removed. And in the nailing group, there was 1 patient who sustained a second refracture, and that was managed with close reduction. And out of 14 patients of the nailing group, refracture group, 6 patients got their implants removed. So the conclusion that they have given is that pediatric forearm, this was the first study to characterize pediatric forearm fractures, and there was no difference in rates of subsequent fractures between ESIN cohort and plate cohort. And ESIN treated, the nails, patients who were nailed had better prognosis, had lesser reach surgery rates. Refractures as well. And then fractures that had undergone previous plate fixation, they were more likely to require a second surgery, while the nailing group could be managed conservatively. The limitations of the study was, firstly, it was a retrospective study, so there was no specific patient-reported outcomes. And this was a very small cohort, so it was difficult to determine the differences between both the cohorts. And one more thing is, all the surgeries that they have mentioned were done at the discretion of the surgeon. There was no fixed protocol that was followed. And the other most important thing is this paper did not discuss whether the refractures were because of the earlier removal of the implant, or whether there were newer fractures after remodeling, which was supposed to be mentioned. So that is what I... So Can't hear you.
So
Sir.
the major issue is whether they have defined a refracture, because there should be a definition that the fracture should happen about a year of index injury, because once the fracture is healed completely, this can be a re-injury. You know, the personality of these children would be that such that they might refracture. So that's one of the limitation, and whether we should, so we should define how many refractures happened in 1 year after the surgery or after the index injury, and that should be defined as a refracture. And once it has healed completely, then if these are the new injuries, so that segregation should have been done, which has not been done in this paper. So we know that ESIN is better. One thing they mentioned is most of these ESIN they have done with open reduction, after open reduction and ESIN fixation.
Yes, sir.
So is there any difference that if you do not have to do open reduction and you can put ESIN, they have lesser fracture rate, or have they discussed that?
No, sir. No, sir. They haven't discussed that part.
Right. So how this would change your practice, Goda, this paper?
So I think I would go for nailing whenever it is possible rather than plating.
Yeah. So they mentioned that even if you need an open reduction, put nails across. But then there are some extreme fractures where you cannot negotiate or maneuver your nails. There you use plates, right?
Yes, sir.
Fine. Dr. Anil, how did you find this paper?
I will first highlight the limitations and then the strengths, sir. It was a retrospective study and the implant choice was at the surgeon's discretion. Okay, they have used the plates, and we do understand in practice then when the plate is applied, the stripping, soft tissue stripping and the dissection required is much more than we classically do for a nailing. Okay, and they have not mentioned about the number of operators or the experience of the residents who have operated the kits. This also makes a lot of difference. Neither they have described the fracture pattern, whether these were transverse fractures, long oblique, because the fracture characteristics also make a difference in the implant choice. Neither they have mentioned about the plate length or the length of the implant which have used. Second thing is that they have removed the implants, the ESN in less than 4 nails were removed within 6 months time and 3 were removed just after 6 months. So 7 nails were removed very early. The classical practice we usually do is we retain the nails at least for a year before implant removal.
Yeah.
So 7 of these implants were removed too early and they sustained refracture. They have mentioned that after the ESIN, the fracture occurred at the same site where it was originally present. I think that bone remodeling in children takes more time than commonly believed. So the message from my side is that whenever you use a forearm plating, you should retain the implant longer. And this study is not defining, as you have pointed out, a refracture or a subsequent fracture are entirely two different things.
And if you are doing ESI, then retain it for at least 9 months to 12 months, and then you remove it.
Yes.
Yeah, the original ESI protocol was they found that in 80% children, it was very difficult to remove these stents if the procedure was tried after 1 year. So between 9 months to 1 year is a good time to remove it. Fine, Goda, thank you. That was nicely read paper. And the takeaway is we have to use ESN as and when possible. Yeah, Meet, please share your screen now.
Is my screen visible?
Yes. Yeah.
Yes.
Today I'll be discussing this paper titled Guided Growth for Treatment of Cubitus Varus in Children, the Medium to Long-Term Results. So this paper was published in Madrid, Spain, and the authors Sergio Martinez Alvarez, Maria Olares, Javier Hernandez, and Isabel Patudo. This was published in the Journal of Clinical Medicine in the 2023. So to give a background on this paper, the authors have said that the guided growth has been used as a minimally invasive technique that allows gradual correction of angular deformity with no requirement for post-operative immobilization. The conventional methods for cubitus varus correction have been lateral closing wedge osteotomy, step cut osteotomy, dome osteotomy, or a multiplanar osteotomy. And the authors have hypothesized that lateral distal humerus hemiepiphysiodesis can be used for gradual correction of cubitus varus. So the aims of this paper were to describe the surgical technique for lateral distal humeral epiphysiodesis with 8 plates, to evaluate the medium-term results of LDHH with 8 plate, evaluate the complications of the technique, and detect factors, if any, which were associated with a higher degree of correction. To briefly describe the surgical technique, on the left is the position of the patient, and a wire is inserted in the capitulohumeral physis, and once that is done, there's a 2 centimeter incision, 1 centimeter on each side of the guide wire, and then the 8 plate is inserted. And after checking both the AP and lateral views, the 4.5 mm cancerous screws are inserted. This was a retrospective study of 15 patients, out of which 12 were males, 3 were females. The outcome measures that the authors have used were clinical, radiological. Then there was one outcome measure which was based on a classification system, and another one on the patient satisfaction. So clinically, the carrying angle, then the flexion and extension range of motions were used. Radiologically, the humero-ulnar angle, Bowman's angle, shaft condylar angle, and the lateral capitulohumeral angle were used. These were just to describe the angles that are the Bowman's, HUA, the humero-ulnar, lateral capitulohumeral, and the shaft condylar angle. The results were analyzed with Stata software version 16. A Wilcoxon test was used for paired samples to compare the preoperative and postoperative parameters. The Mann-Whitney test was used for further subgroup analysis. Moving on to the descriptive analysis of the paper, the median age at fracture was 3.3 years. The median age at surgery was 5.1 years. The median follow-up that the patients, that the authors have kept was for 81 months. And the median implant duration, for which the implant was kept, was 72 months. So if we have a look at the results, the carrying angle, the humero-ulnar angle, Bowman's angle, shaft condylar angle all had a significant, highly significant change, a highly significant p-value in the pre and post-operative. There was a big difference in the flexion. Also, the other flexion extension, the clinical parameters, and the LCH, the lateral capitulohumeral, were also significant. However, the coronal plane deformity, as has been described by the authors, was significantly corrected. So the authors calculated the correction rates on the basis of this, and they found out that the humero-ulnar angle had a correction rate of 2.4 degrees per year. Bowman's angle had a 1.5 degree correction per year. Shaft condylar angle had a 1.3, and the lateral capitulohumeral angle had a 0.75 degree correction per year. On performing a correlation analysis, the authors found there was no correlation between the age at time of intervention and the degree of correction. There was no correlation between the age at the time of intervention and the humero-ulnar angle. However, the implant duration and the degree of clinical and radiological correction was statistically significant for the carrying angle, the humeral and the Bowman's angle. On measuring the patient satisfaction, the authors found that the implant duration, the initial carrying angle, the initial humeral angle, the correction of the carrying angle, and the humeral angle correction were found to not be significant with the patient satisfaction. However, they found that the age in the group of patients who were satisfied with the outcome was much lower as compared to the ones that were not satisfied. The p-value was, as we can see, it's 0.037. Moving on to complications, at least one complication was seen in 6 patients, which as the sample size was 15 patients comes to 40%. The aseptic screw loosening was seen in 5 patients, out of which the epiphyseal screw was found to be loosened in 2, metaphyseal was found to be loosened in 2, and both were found to be loosened in 1 patient. The authors further analyzed these subgroups and they found that this was more related to the suboptimal technique and the screw length. This is the classification system that was used for the modified Clavie and Dindo Sink classification system, where the grade 3, the 4 patients were grade 3 and 1 patient was grade 2. Moving on to discussion, the authors have stated that this was the first published series of cubitus varus correction with lateral distal epiphyseal disease using 8 plate. Recently published by Soldado et al. In 2022, they had used medial oblique cannulated screws, and however the sample size was of 5 patients. The mean age was 3.58, and the follow-up, however, was limited to only 46 months as compared to 81 months in the current study. The author distal humerals accounts for 20% of the limb growth, and the authors have said that since there was no relation between the age at the time of the intervention, the authors have found that this growth has remained constant, and so the approximate rate of correction is 2.4 degrees per year. So just to give a brief idea, so the author has said that for 12 degrees of correction, for bringing it up to neutral, the time required is 5 years, and the further 3 years will be required to achieve a normal 8 degrees of valgus. Some limitations that I found with the study was that the sample size and retrospective nature, as the authors have already stated. However, the authors have also included patients who had ongoing correction, the implants were not removed, or the skeletal maturity was not attained. So this, I think, is a limitation because it could contribute to better results of the study. And standardized method of radiographs was not described, as the technique has attained 2.4 degrees of correction, which is quite a small number. So it can be, so we have to eliminate human error from the calculation. Thank you.
So, the first the point is cubitus varus is not the only coronal deformity. It's a combination of sagittal deformity as well as rotation. Now these authors have considered only coronal correction. We know that some of these patients, they lack complete elbow flexion, so they have not mentioned that what has happened to the sagittal deformity and whether they had any limitation of flexion extension. So that is one point. And the other thing is they have not mentioned that what are the complications of this procedure about elbow stiffness. Was there any episode of elbow synovitis, or so they should have mentioned that even in the negative form. And finally, it's 2.4 degrees a year. That means we usually see children getting this fracture between 3 to 6 years and they heal. So with the cubitus varus, they would reach to you at 7-8 years. And then if it's a gross deformity, then this technique cannot be applied because it will not lead to complete correction, So the major limitation is the authors are thinking in terms of only AP or coronal deformity. They should, I'm interested in knowing that what happens to their, because most of the Cubitus varus also have the extension deformity in the distal fragment. Yes, Dr. Anil, what is your take on it?
I think, sir, regarding this paper, it was a negative studies published in a positive form.
That's
okay. Okay, if you study carefully, they have dealt deformities only up to 20 degrees, whereas in our clinical practice, we see more severe deformities than this. They have refrained from mentioning time since injury. They have said that the average age in which they have used the implant is 5 years, but they have not mentioned how long prior or how prior was the injury after which they have this deformity. The technique they have described in all the x-rays, I found that the screw is protruding into the olecranon fossa. And if you have dissected a case of for a supracondylar or a lateral condyle, you see how thin the olecranon plate is. So to put a plate and saying that we have not violated the olecranon plate, and all these x-rays are showing the olecranon screw protruding into the fossa. They have used the implant for 5 years. If you listen to Peter Stevenson's lecture, they say that beyond 2 years, it can affect the physis characteristics. So more than retaining the screw for 5 years is somewhat not a practice which is established. And they have not mentioned anything about the status of the physis at implant removal. They have not accounted for any spontaneous correction, or they have not used the configuration of measurements of the opposite elbow to tell us whether in these cases, even if the implant was not used, whether spontaneous corrections will occur because the physis was healthy and their children were too small at the time of implant. At the time of final follow-up, the carrying angle was 6 degrees residual. So they were not able to fully correct the deformities in all their patients. And if you look at the statistical analysis, they have mentioned that the extension remained 0 to 0 degrees, and yet it was significant in their study. So this brings out the limitation of the low numbers and the statistical dilemma which you face with the small numbers. And they have a high complication rate of almost 40%.
Yeah.
And they have not mentioned the other complication which you have already pointed out. So I think it is a weak paper. Just they should have published in a negative form rather than a positive form.
Right. So I agree with your comments. The only takeaway from this paper, who are in die-hard fan of growth modulation, the pure indication of this procedure would be smaller degrees of deformity, isolated coronal plane deformity with no rotation and extension deformity, and in younger children. And you have to be ready for implant replacement. 1/3 of, so every one child in 3, they require a replacement of implant. I feel that the magnitude of Cubitus varus correction and the significant deformities, unlike the distal femoral thing, because with Cubitus varus we fix with K wires, so implant removal is also not a very big surgery. So we cannot contemplate genu valgum correction within Cubitus valgus. We have to remember that the elbow is a less growing end of this, so the correction is going to be very slow, and on the path of correction we will see a lot of complications. So I'm still and they have not mentioned about the complications, so we like to inquire with the authors that what sort of stiffness, range of motion problem you have found in your series, and I'm skeptical of using this growth modulation in Cubitus valgus. So any fellows or any comments, it's welcome. We have 1 minute to go, or we can discuss on fellows group. So all papers were well read. Dr. Anil ji was, it's to learn from him that what sort of points the reviewers see when you submit a paper. And even the papers published in JPOA or big journals, they might have limitation and some mistakes are overlooked. Reviewing this paper gives an opportunity to write letters to the authors and reviewers also. So journal club should be utilized that way. Yeah, so if there is any comment, then it's fine. Otherwise, we'll wind up. And sorry for some technical goof ups from my side. I have to check it. Yeah. Okay.